Okay, our next panel up, Arizona AI Health Innovation, meeting Arizona's future health needs. Our moderator for this particular panel is Dr. Jason Wertheim, Associate Vice President, Health Research, Office of Research and Partnerships, Professor, Department of Surgery, College of Medicine, Tucson, University of Arizona. Jason.
Okay. Well, thanks so much. I want to introduce and bring up to the stage, I guess, or our panel area, our four panelists. Dr. Adhikari. Dr. Adhikari is Professor of Emergency Medicine in the College of Medicine, Tucson. He's Director of the Emergency Ultrasound Fellowship, also in the College of Medicine. Our next is Dr. Onicio Batista, Leal Neto. Come on up. Dr. Neto is an assistant research professor in the Mel and Enid Zuckerman College of Public Health here at the U of A. Dr. Frederick Chang. Dr. Chang is Chief Medical Information Officer at Onvita Health. And Dr. Gondy Leroy. Dr. Leroy is Associate Dean for Research and Professor in the Department of Management and Information Systems in the Eller College of Management here at the University of Arizona. I want to thank you all for coming to our session. So we're focusing here on Arizona AI health innovation, so meeting Arizona's future health needs. It's really a pleasure to see everyone here. We're coming from different areas of the state, health systems, academic institutions. In fact, we're all in this room speaks to something important, that Arizona is not just participating in the future of healthcare, really we're shaping it and really providing direction. But we're at a very unique time here in the state's history. Our population is expanding rapidly. Older adults are increasing in prevalence. And at the same time, we face a persistent health challenge, chronic disease, rural health access, gaps to really getting care, and behavioral health needs and workforce shortages throughout the state, particularly in the physician community. This is present in Flagstaff, in Tucson, in Yuma. We have folks here from Yuma, even up to Phoenix, where one of our medical schools is located. And so we really want to ask some of these questions of how do we deliver care more efficiently? How can we reach patients in rural and tribal communities? How AI can help us address some of the rising costs to healthcare? How can we capture some of the billing practices? And we heard that in the last session. And how do we improve outcomes while preserving kind of the humanity of medicine? And so, artificial intelligence obviously is here. We're utilizing it in different capacities. There is different efficiencies and different accuracies. And we talked about that in the last session as well, too. And so predictive analytics can help identify patients at risk. And AI-assisted imaging can improve diagnostic accuracy. And natural language processing helps to reduce documentation burden. Some of those things we heard in the last session. And so AI is changing that and how we deliver that particular care. What makes this moment different, however, is not just the technology, but it's also the urgency. And so from across the country, all 50 states are really trying to address the need in healthcare. And so how can we address that uniquely from an Arizona perspective? And so health systems are strained. Clinicians do face rising burnout risks. Costs continue to escalate, and communities expect more accessible and also personalized and equitable care. So AI offers these tools that can help respond to that scale. And so Arizona has several advantages that position us as leaders in healthcare systems and in AI-driven health innovation. And so we really want to leverage academic clinical partnerships, and we have several of our clinical partners in the state here today. We have a diverse population within the state, includes urban and rural communities, border regions, sovereign tribal nations. Designing AI solutions here can force us to think about equity, language, cultural relevance, access from the beginning. So there's a growing health tech ecosystem in our state. So startups and health technology companies are increasingly choosing Arizona as a base for innovation, supported by favorable regulatory and a business climate. And there's real-world testing grounds, and our demographic diversity can really help us realize that, and to pilot and evaluate new AI solutions from large academic centers to smaller community clinics, and change that as the scale modulates. And so when we meet Arizona's health needs, we want to define that. And so what we mean by our health needs in the state is our aging population that's requiring more chronic disease management, increasing rates of diabetes and cardiovascular disease, expanding behavioral health needs, ongoing provider shortages in different parts of our state, and particularly in rural communities, and also climate-related health changes and challenges, particularly heat exposure, skin cancer as an example, valley fever, and cross-border public health coordination from one state to the next, and even across international borders where we live quite close to. So predictive models can help identify high-risk patients earlier. Remote monitoring tools can support aging in place, and so the School of Engineering has been at the forefront of developing different wearable sensors so we can monitor chronic disease at home. There's AI-assisted triage can help expand workforce capacity, and also data analytics to help guide health resource allocations. And so we have some critical questions that we're going to ask at this session, both to our panelists as well as to the audience. And so things that we want to think about is how do we ensure patient privacy and data security as we expand AI technology, how to prevent bias in algorithms that could worsen disparities, and how do we regulate responsibility without stifling innovation? So where's the balance between regulation and expanding the technology? And how do we train the next generation of clinicians to work effectively with AI tools? And so that goes to some of the workforce development and education concepts that we discussed earlier today as well. And perhaps probably most importantly, how do we keep all of this human? How do we retain that humanism in medicine that a lot of us learn about in medical school? And so collaboration is key. And so that's one of the take homes from our day today is how can we collaborate across academia, clinical practices, industry, government, and community engagement, and develop these cross-sector collaborations to advance AI in health, particularly public-private partnerships, where we need community voices to be at the table at the very beginning. So as I particularly close and kind of pass this off to our panelists, we're designed to now to bring together the leaders who are working at the forefront of transformation. And so they represent diverse perspectives from research, from implementation to policy, innovation, patient care, and together we're going to help explore where we stand today in Arizona, what are the opportunities that lie ahead for us, particularly in AI and health, what barriers do we have to foresee in the future to navigate around, and what concrete steps can we take care of to ensure that AI preserves the health for all Arizonans? And so this is not just a conversation about technologies per se. It's essentially how do we implement that technology to develop workforce sustainability, responsible innovation, and about building healthcare systems that are intelligent but compassionate at the same time. And so we've always stated our goals to grow, to be resilient, and have bold thinking throughout the state. The question is, if we can lead thoughtfully, inclusively, and strategically using AI to meet the health needs across the state and throughout our communities. And so I'm excited to begin this conversation with our session here. So I'm going to turn this over to our panelists to give a few minutes of introduction about their research. And then I have some questions that I can pose to each of them to help the discussion, as well as then opening this up to the audience here. And so we have a packed room this afternoon, which is terrific. So with that, I'll toss this over to Dr. Adhikari. We're going to just kind of go down the table there, and each of you can give a brief introduction of where you're working, and then particularly kind of the research implementation or different areas where we're advancing AI in your space.
Can you hear me all right? All right, I'll just speak loud. My name is Srikar. I'm on the faculty in the Emergency Medicine Department. I practice emergency medicine here at Banner. Like I mentioned earlier, my area of interest is diagnostic technologies, primarily ultrasound related. Currently we're working on specific projects focused on developing.
Oh, it's just not. I tried.
Good. All right. So our focus is on upskilling healthcare workers in terms of ultrasound image acquisition, ultrasound image interpretation. One of the things which bothers me a bit, I was in an industry meeting yesterday in Los Angeles. Seems like many of our partners on the industry side are developing technology because they have the capability to develop the technology and kind of forcing into the existing workflows, and they don't seem to work. So that is one of the problems I'm noticing. So as a clinician, what I have been doing, and also when you want to apply for federal funding, the main thing is you have to recognize the problem, the clinical problem, and how potentially the technology could solve that problem. So what we have done is we know we work on two conditions. One is retinal detachment, other one is pulmonary embolism. One is funded by DOD, the other one is funded by NIH. Both of those we're working on upskilling the healthcare workers to acquire the images as well as interpret, and we have models to show the explainability, why we're providing that interpretation. That's part of my research. And more recently, I've been fortunate to get the Big Idea Challenge Award. Our team took over a very ambitious project, which is developing a health kiosk to improve healthcare access. We're hoping to see if not only integrate HealthBot into the health kiosk, but also provide diagnostic testing, as well as some medications at the kiosk. Obviously, like I said, this is a very ambitious project. This is what we're currently working on. Thank you.
Hello, everyone. My name is Onicio Batista Neto, and I'm a faculty at the College of Public Health. My main research topic in the areas that I used to work is digital epidemiology and digital public health. In our college, we manage a program called Global Flu, which is one of the few digital ecosystems out there that manages 21 million data points from different countries. We have 11 countries right now, towards the early identification of influenza-like illnesses based on participatory surveillance, which means based on direct community participation. So people helping to build the epidemiological setting around influenza. Another research topic that I do stuff is utilizing wearable devices and digital biomarkers to understand infection routes in long-term care facilities. We have already one project that's up and running that we are trying to leverage these proximity sensors, face-to-face contacts, and social contact structures to understand how that resonates with resistant microorganisms on those settings, and how, because we are collecting this high-resolution data, how we can leverage this to create more assertive synthetic data, and that's extrapolate these findings for other geographies. But maybe one of the most important things that I'm doing on my daily life is preparing the next generation of public health professionals. So we are working hard in our college to give public health students opportunities to close the gap about this entire conversation of AI and machine learning. Because here's the thing, we do have a huge gap. And it's very easy to come here to start talking about generative AI and all of this stuff. But if you are not building the basis, the foundations of it for the next generation of people that will be managing county health departments, for example, what's going to be in the future, right? And that's why we are tackling that not only for students in our undergrad and grad programs, but also give opportunities for people that got their train in public health to come back to academia and having these short trainings so they can get up to speed in this sense. Thank you.
Good afternoon. My name is Frederick Chang. I'm the Chief Medical Information Officer at Onvita Health. I actually represent, I guess, not someone from U of A, although I am a proud graduate from the University of Arizona's Clinical Informatics Fellowship in Phoenix. So worked at the Banner Health Enterprise for some time. I'm still remote faculty, so I do teach informatics fellows about AI, but for my day-to-day job, I mean, my job is really the operational deployment of technology for our providers and really our health system in Yuma, Arizona. So if you're not familiar with Yuma, it is in the southwest corner of Arizona. We'd say the population's around 150,000 people during the winter or during the summertime, and then during the wintertime we have snowbirds, so that floats almost up to 200 to 250,000. So you can understand that during the wintertime, we get very busy in the healthcare system as people get sick. And so one of the biggest focuses of my technology deployment is how do we address workforce labor shortage, because all of a sudden our population has inflated and our emergency rooms are very full of patients. I think the other couple interesting things are that very soon we are also building a hospital in San Luis. So now we have to start to think about how we're going to use technology, potentially telemetry or televisits, as well as using AI to help more efficiently practice as we're trying to address other community needs. Finally, I would say that for Onvita, it's a growing partnership. It's really exciting. In the late winter of last year, we announced that there will be a medical school track with the University of Arizona. So, we're excited that Onvita can help provide medical students in the future, not only to learn about medicine, but use of AI in a rural setting. So, thank you.
Okay. Good afternoon, everyone. My name is Gondy Leroy. I'm the Associate Dean for Research in the Eller College of Management. I mention that because part of my day job is connecting people in terms of research, any kind of research. So if you're looking for a collaborator, just reach out to me and I'll find you somebody in Eller who can help. The research part is focused on healthcare in my case, and when I think about it, all my projects really focus on technology as technology in the loop. And so for the different projects, I can give you a few examples, but we use machine learning these days in all the projects. It's really nice. We've been doing machine learning for 20 years, and it's good. It's AI again. It's good to be hot again, because, we were not 20 years ago. But it's good. We're back in. So in terms of projects, one of our longest running projects focuses on health literacy and improving health literacy. We provide easier to understand text and audio. And you can imagine with ChatGPT that we had to take a huge pivot in the middle of that project, because all of a sudden when that came out, we were obsolete and we had to start doing new things. So it's very interesting now. We have different approaches to doing that. We also focus on valley fever and autism. And in both cases, I would say we try to build decision support systems that help pre-diagnosis. And I think that's important because that can help make the decisions transparent. There is a whole research stream that looks at transparency after the model has made a decision and tries to focus on what influenced the decision. We try to build our models so that they can be helpful before a decision is made in both cases. So for valley fever, I look at the personal patient characteristics, but we're also going to combine that with. So that's together with the Valley Center of Excellence. For the autism, same thing, we focus on diagnosis, but we focus on labeling kids' behaviors using either clinician language, and now we're switching to bringing it to the home, having lay people describe the kids and assigning diagnostic labels to that. And then related to that, you always have a few angles, right? So we're also getting into avatars for autism, which is really interesting. We have a poster on the avatars. Please stop by later and you can talk to the student. We also have a poster on valley fever with our excellent results. So please stop by for that one too. And then I would say the last part, which I think is relevant here, is that in Eller, we're doing a lot of executive education. We're doing a lot of education, but we are also doing a lot of executive education. And recently, we started focusing on education about AI. And so I think being part of that has shown how necessary this is. These series currently are not necessarily focused on healthcare, but it shows us that people need better understanding, even if it's basic understanding. And I think the healthcare field would certainly benefit from that one too.
Great, thank you so much. So with that, we're going to move into the question and answer phase. So we're going to do a quick mic swap, but if there's any questions from the audience, you can take that now. Otherwise, I'll step in and ask a question as soon as we switch. Okay, can you all hear me okay? All right, great, thank you so much. So I think, first question to Dr. Adhikari is, as an emergency room physician, we talked a little bit about decisional support tools and so forth. And so if you're talking about ultrasound as an example, or if you're in a situation, in a clinical care situation in the emergency room where seconds matter or so, how do you envision AI augmenting this decisional support and ultrasound potentially, in particular, in the care of a patient in an emergency room setting?
Yeah, I feel like I'm in the Pitt show. You guys watch Pitt? Anyway, it's on HBO. So they don't show anything about AI. So I think the greatest promise for AI lies in amplification without intrusion. So what do I mean by that? So as physicians in the room know that when we log into EMR, we have so many alerts, and all we did was we learned how to bypass those alerts and just click it or type a period and click it and just go to the other screen, right? So we have mastered that, but really those alerts. So we don't need more alerts pop-ups, right? So what I mean by that is these models have to run in the background, and they only have to surface when there's something meaningful inside and actually would make a difference in patient care. I think that's number one. Second is we have already seen ambient AI documentation, how much that made a difference. And I think there's one of the large corporates data was published essentially for 2 million or 2.5 million visits, about 18,000 or 19,000 physician hours saved, and more contact with the patient while they're in the room. So definitely, I think that is lowering the burnout. I think that's makes a big difference in the ED. But there are 3 or 4 practical issues, and these are more operational issues, which make a big difference in our case. The one thing is when a patient presents, just digging into the old chart, old encounters, old previous imaging reports or labs, just enormous amount of time. This puts a significant burden on the physician. The models are now being developed where they'll capture all the data and summarization of the data relevant to the chief complaint. I think that's a game changer for us, because now we can actually provide meaningful recommendations in a very short period of time. And the second thing is, which has been well known to a place where mistakes could be made, is the handovers. Essentially, any given shift, I probably take like 30 patients from my previous, from my colleague from the previous shift. So, and you can understand the burden, the cognitive load when, how much notes I will take, how much you can type while you're transferring the care. And if there are only models which actually can summarize the most important critical findings and the meaningful things, and I think that's actually it becomes a patient safety issue. And the last thing is, as much as we would love to talk to our consultants and hospitalists and whatnot, but that is a significant burden on us every time we want to summarize the case, why we're consulting, why we're admitting this patient, long length of histories and physical exam findings and whatnot. So this puts a significant burden on us as well. And these are all like factors for fatigue as an emergency physician, which would pretty much takes toll on you by the end of the shift. And this is where mistakes are made for most part because of the fatigue. And I think these operational issues can definitely be sorted out AI. And I know talking to even, like I said, I was at a meeting yesterday, there are models being developed to address all of these issues.
Great, thanks so much. It's really a lot of insight there in the context of how do we implement this in a clinical setting. Dr. Leal and Neto, in public health sphere and in digital epidemiology often relies on kind of non-traditional data, possibly not quantitative, maybe more qualitative. How can AI implement that in a context of public health, even across the state, disparate communities? How do you see that in the future, accelerating research in that area?
Yeah, it was really funny. Not the pandemic was funny, but it was funny. One thing that happened during the pandemic, every single modeler, every single data science researcher was shocked about something that we see every day in epidemiology field, which is underreporting. And no matter how sophisticated their model were, their model is still failing hard in trying to predict what happens next week in this sense. It turns out in digital epidemiology, there is an area that exists for maybe 15, 16 years now called participatory surveillance, which is the bidirectional process of having community feeding government or public health agencies with their symptoms data in a very fast way, real time. And there are tons of evidence showing that participatory surveillance can predict the trend of some disease occurrence, sometimes in 1 week in advance, sometimes in 2 weeks in advance. And it's a pretty obvious, right? Because between you get sick and between you get accounted by a health system, there is a gap. And there are a lot of cases that will never ever reach out the health facility to be accounted. That's why participatory surveillance has this value. And during COVID, we had the opportunity to start bringing more and more machine learning approaches to deal with this data. And of course, participatory surveillance data is not a perfect one, but it can complement in a very interesting way traditional surveillance sources in this sense. So I think digital epidemiology for the pillar of early detection is something super important that we need to care about. And just one more thing on this sense. We host in our college a program called EpiCore. So basically is a huge network of public health professionals that do rumor verification. So basically they are the eyes and ears of every agent that need to check if that rumor is true or not in regards to some disease outbreak or epidemics. So things like that have community heavily involved are key. And we need to look at this and see what else we can do or how far we can go when we bring artificial intelligence, machine learning to support this sort of approaches.
That's great. Well, thank you so much. Now we have someone, I think, with a microphone. If you have any questions, just raise your hand kind of in the audience. I have one person in the back there. Thank you so much.
Hi, thank you for the wonderful panel and the day. I'm Dr. Kirshner, Joe Kirshner. I'm a pediatric ear, nose, and throat surgeon. And so when we have these conversations, we heard it today a little bit about whether AI will replace doctors or healthcare providers. And there seems to be trepidation from the medical field about that comment. I read your title about, meeting Arizona's future health needs. There's not a single state in the union that doesn't have a shortage of physicians and nurses. And we're not anywhere close to being able to solve that. I mean, it takes a long time to mint a new doctor or a new nurse if you go all the way back to undergrad. So I'd be curious if the panelists wanted to comment. I know our moderator's a surgeon, so we're a long way off from AI going into the operating room and doing a splenectomy or something. But I think we're very close to having AI be able to replace many things that maybe were pretty common. I'll just give one example. In my world, I spent the last 20 years working with research. We're not very good at diagnosing, in my world, ear infections, right? And machines can do that better actually than clinicians. And actually, the technology exists today to employ those. So that kids probably don't have to go to a primary care doctor to have an ear infection diagnosed. Now, there's a whole nother piece of psychology about whether or not you should see a doctor or not. But I just be curious if anybody on the panel has a sense within your training folks in ultrasound and the emergency room and other places in health systems, why we as a medical field are so trepidatious about this concept that AI is going to replace physicians. I mean, it'll replace things that physicians do. Those doctors have plenty of work to do if they go into other fields. So be interested to hear those comments.
That's a great question. In fact, in general surgery, we're doing surgery with a robot, but the robot doesn't have AI, though. It's controlled by the surgeon. But anybody there want to comment on that question?
I think that's a great question. I'm not sure if every physician feels that way, or are we divided, in how we feel about it. The one thing comes to my mind is, I know you talked about physicians, but implementation and adoption are not at a large scale at this point. Which is, even if we talk about ear infections, we're diagnosing ear infections in a very traditional manner as of today. Even ultrasound, even though there is a lot of models guiding providers to acquire images and so on, but a large number, if you look at the percentages, more than 90% are being acquired manually. So that's number one. We haven't adopted or implemented we didn't scale up yet. And the second is the trust factor. I don't believe patients are ready. I know they use for ChatGPT. I think there's like 1 in 6 use ChatGPT for medical recommendations, but I think it only goes so far. I don't think the trust is there among patients and among the public to take an advice from an AI bot and just be happy with that at this point. So as much as there is angst about, AI is going to replace physicians, I don't know that is universal at this point. I was going to answer Jason as a question about, I can say this now, I guess. I still think, and somebody in the audience pointed out that as well when we're doing the previous panel, that what if we do something what AI doesn't recommend? Who is liable and how that works? I just feel like at this point, hospital committees are, staff, medical staff, chief of staff, or whoever, still need to enshrine physicians' ability to override AI's recommendations. That's where we are right now, and it's a great question. I don't know if there's a lot of data published, but definitely, I even heard today, we are going to go to the ambient AI documentation, and there are several physicians who are actually concerned that, I'm not ready for this yet. So there's definitely that, but I think the large-scale implementation isn't there, So
I trained about 20 years ago in surgery, and that was when laparoscopic surgery was kind of really at the forefront and increasing in prevalence throughout the country. So I went into transplant surgery because I thought you could never do a liver transplant through a laparoscopic incision. So the liver is about this big.
Sorry, can I comment real quick? I think my take on this is really, I think the core identity of a physician is our autonomy, right? We've learned this art of medicine. And I think what's that trepidation is you have something that's going to disrupt how we practice medicine, right? And I think, you can already look at other industries where large language models like Anthropic is disrupting the whole software service. And we really don't know where it's going. And so when we lose control of our autonomy in the way that we can practice now, I think that's where we're scared. And I would say that I think we need to really be in the middle of it in terms of physicians, leadership from academic institutions to kind of guide the big tech. Like, I'm going to say probably some controversial things, but I think big tech is really controlling the future of how healthcare is being delivered. You're seeing how ChatGPT, Sam Altman, they've already gotten into the LLMs and deploying them at the patient level. I would say, I know that we think that patients aren't using it. We use Epic, and I talk to our Epic partners. We look at the inbox messages. We know how much patients are actually responding back to doctors with ChatGPT or Perplexity or whatever LLM. And so I think the biggest issue, and I kind of tie it back to the rural health part, is if you can't solve patient access, where are patients going to go? They're going to go to the chatbot. They're going to ask for help. They're going to ask for triaging. And so those are out of our control. So if we don't partner, and that's my personal belief, we can, everyone can have different conversations of how to go about this, but if we're not part of that discussion with these technology companies, they're going to disrupt our field. And so I think that's where the issues are. And so really encourage, if you have academic leadership, is to reach out, don't be shy, and try to work with them. We know Arizona is the hotbed of technology now. And so I think it's really important that we try to use that geographical proximity to really empower these big tech companies to listen to physicians. So
that's great. Go ahead.
Yeah, can I add a comment to that? So I love it that you say that some of the models can diagnose ear infections better than you can. We see some similar things. We have translated videos into avatars, and our models are really good at recognizing kids with autism, and the humans are not anymore. So there is definitely a place where models can do a lot better. We've also interviewed pediatricians, and they claim, we interviewed, I think, 16 or so, all of them claimed they never missed anything. But the diagnosis of autism is on average about 4 years, and it should be at 2 years. So obviously something is being missed. So I think technology is moving really fast. I think we have to be careful that implementation doesn't go faster than the education about it, and that the privacy and policy are clear to people. But I think if we can kind of coordinate these together, so the education, so that it's not a magic box, but it becomes a tool for people that they don't have to be scared of, I think then we can get further than we are now.
That's great. Terrific point. I want to go back to the audience. Dr. Slepian, you had your hand up, the microphone coming.
Thank you very much. I was going to comment on this rather than ask a question, and it kind of hits on some of the points that everybody made. I think, first of all, physicians have to look at AI as an augmentative tool. We heard that a little bit, but I want to reemphasize that. Humans created artificial intelligence. We have to stay in front of that. And I think that's an important point. Even in the last conversation where we were having the debate about, are we humanizing the AI like a workforce member? So I think we have to remember that if you want to go forward, and we also heard it in terms of developers, that engineers develop yesterday's products tomorrow because they don't really understand the market and know the details. So I think point number one is physicians should be leaders as far as developing and helping and working with engineers and everybody else. It's really to Dr. Chang's point about how we have to be at the forefront as far as guiding where AI fits. That's point one. Point two, related to our surgical colleague over there, I think, even for simple things, when you made the comment today about, the ear, I just came from clinic. I wasn't here in the morning. I saw 15 patients, a lot of patients with complex hypertension. You could tell me, hypertension, that's such a common thing. Why can't we just go through, pull out some stuff from the EHR and tell us, based on guidelines, which there are plenty, about what to use for the patient? I think even in that common circumstance, no one patient is the same. And the same goes for AFib and hyperlipidemia and diabetes and all the top diseases. But there, AI can be very helpful to pull up some guideline nuances, to look at certain things. But at the end of the day, I still have to make the medication choice because they don't know every single environmental factor, every single personal factor, all the natural history of the patient, which I have. So that's where AI can deburden me to allow me to now get back what was said before in the last session, to being more personal and spending more time with the patient to understand their nuance and then give them the right medication. So I think we have to think about it that way. It's not going to replace us for a lot of these things. And I could go on, but I'll stop there.
Great. Thanks so much. Terrific comment. I'm going to bring it back to the panelists and ask Dr. Chang. At Onicio Health, how do health systems evaluate return on investment, or how do you perceive in the future we're going to do that? Because I think ROI's been in the news in a lot of the tech companies nowadays at looking at, well, what's the future return going to be? How do you think of that, 5 years down the line? What are your goals?
Sure. I don't think there's going to be a straightforward answer, but I think the way that you should evaluate what AI tools to implement is it should be aligned to your organization's strategic goals, right? So at Onicio Health, obviously, increasing patient access is really important to us. We did a community needs assessment, and we know that our community members really want more psychiatric services, so we started a psychiatric residency. So yes, the financial part of AI is always the juicy part, or a lot of times if we get a ambient dictation tool, potentially, the doctors will see more patients and then we can, potentially get more financial return. But the way that we have approached it is our strategic goal is to increase the patient access. And how do we do that? We know that we really need to retain our physicians. If we can't retain our physicians and leave UMA, our patient access gets worse. So we aligned some of our AI tools around how do we reduce cognitive burden? How do we make sure that physicians want to come here because we have the latest AI ambient dictation technologies, and then retention. If we could reduce all those things, believe it or not, we never made it a mandate that our physicians see more patients using ambient dictation, but they actually naturally started to see more patients on their own because they were like, I feel really great about this. I feel like I could take care of more patients. And so when you kind of look at what is your goal and keeping the patient centered, I think that's really important, because if you start driving down the financial side, it leads into some pretty dark areas. So that's kind of the way that we've kind of looked at it. So.
That's great. Thanks so much. And again, from the audience, if you have questions, just raise your hand. We have a microphone. We're coming around. I'm going to go over to Dr. Leroy. Just talk again about some of the research that you're doing in the context of AI. How should business schools kind of look at the implementation of AI and innovation, particularly around commercialization? What's Eller doing from an AI perspective at training some of the students in workforce development who are learning kind of the business of AI?
Right, that's a big question. I cannot speak for everybody, but we do have AI in our courses, a lot of courses. We have special programs, for example, Excel, national, like championships in Excel, starting to add AI to that. We have AI in all our courses. We have online programs that teach that. We have people who do policy on that and all of those things. We have the McGuire Center, which can help with more the business needs, startups. So we have a lot of these things that you expect in a common business school, right? But we also have the more technical side, which is not common to a business school. And so we have quite a few people who actually build applications and implement them. And I think what is different for being in a business school is that most of these projects, they focus on how it can make an impact, not just, and I love foundational research on models and all that, but more like how can these models, for example, make an impact in patient lives? So always keeping the employee or the customer or the patient in mind when we do these projects. So I think that's one of the things that distinguishes Eller in terms of the AI that we do.
Great. That's terrific. I want to throw out a couple of questions just generally to the panel and to the audience as well. If we're looking at now, for the last 10 minutes or so that we have, about where we can invest in AI in health, where should we deploy our funds to advance healthcare in the state, research in the state, utilizing AI? What are some of the sweet spots or high areas of return on investment that we would want to scale up over the next 5 or 10 years? So thoughts on that from the group.
I think, the gist of, at least when you're practicing in a rural health system, again, is really patient access. So I'll keep harping on that. And, is it that you're able to relieve some of your workforce with generative AI tools such as ambient dictation? Is it using some of this generative AI in your phone trees? So we're starting to look at ways of, can we use generative AI for patients to make their scheduling, and that goes back into the Epic system so that we can relieve some of the problems with, it's really difficult sometimes as patients to call into our patient access department. So I think that's the area that I feel is really where we really need to work on in the rural space. So I would say that's probably where I would go.
So access, workforce development. Go ahead.
Yeah, for me, I think there is the buzz of predictive analytics or forecasting models and all of this stuff. But sometimes we forget to do the basics well, right? And AI can bring opportunities for doing nowcasts and understanding better the health threats that are affecting the communities right now. And this conversation since the morning is been around workforce training, but this is maybe one of the most urgent problems that we need to tackle. And at least in public health area, one gap or one huge challenge that I see is because most part of those machine learning, deep learning models, they lack of interpretability and explainability for people that don't have a background in data science or computer science. So how to achieve that? And there are a few things that we can do that are low-hanging fruit. For example, start teaching people from public health understanding model cards, or even producing these model cards, because in a model card, it will bring the benchmark, it will bring the performance, it will bring the reason, the rationale. All of the things that are important for convincing someone to adopt this thing. And if you are doing adoption, then at least for public health capacity, we are addressing the last mile in delivering health promotion or disease surveillance in a better way, using all of these things on AI and machine learning.
I think operational efficiency, I think that's a very high yield and a low risk area where I think AI could make a difference. I've already given you a few examples. Obviously, ambient AI, listening and documentation is one of them. But I would, most of the physicians would agree, I don't think we need a lot of help to diagnose, whatever condition, but we are inundated with the operational tasks, which are ever-ending tasks, right? I have to learn almost every week a new protocol, who to call, when to call, and whatnot, right? So if only some of these models can simplify the workflow issues we have, or even as simple as how many of you had difficulty getting a primary care appointment? And that includes myself as well. So all these operational scheduling issues, if we can solve that, these are low risk, right? These don't have any medical legal liability attached to that, but these are high yield. This is where the patient satisfaction comes from, and physician burnout is going to decrease. For me, it's going to be the high yield one is going to be solving the operational issues.
Can I make a comment? So I love all of this, but I also want to add that we have to keep on thinking about the patient at home. And so when we were asked for this panel, we had to focus on rural, right? So I think rural can mean that you're far away from the office and maybe you have kids at home and maybe it's a 2-hour drive. So I think AI, telemedicine, all of those things can bring the office closer to the home, which is very important, I think, for rural health. And I think there are a lot of opportunities that go way beyond just some video conferencing, where we can bring that and make the life of the patient easier. And maybe it's going to take a while for the services to be that good. The other thing I think is some of these tools can make the non-experts, because there is a lack of experts and there's sometimes 2-3 year wait lines to see an expert. Maybe we can help the non-experts become more of an expert with good decision support. I'm not sure how that would work in terms of oversight and who's going to get sued for what. But I think there are opportunities to make the life of the rural patient a lot easier with AI. And I kind of hope that's the case.
Right, thanks. Yes, question. Do you have a microphone?
You can take this.
Oh, that's sorry. Okay.
And I'm going to preface my question with there may not be a good answer to this. It may just be a problem that I've heard a lot about, especially in the rural space, the challenge we have with access, which I think we all recognize is an issue, has always been an issue, and is unfortunately looks like it's going to continue to be an issue just given physician shortages, staffing shortages. What's fascinating to me from a business perspective, I don't know if there's been any research on this, but what about the inverse of this? So we have a very fragile healthcare delivery system. With AI, especially under value-based care contracts where we're incentivized to look for things proactively, right? Let's say you find needs and preventative services much earlier than we previously did before. And I'll use geriatrics as an example. So you have low-income older adults. Turns out you find out there's nutritional needs, Meals on Wheels. You got to set them up with transportation services, a whole host of things that maybe you are able to now forecast you didn't weren't previously able to do so. Last time I checked, at least within the states I've operated in, there's a pretty long waiting list for a lot of those services. And so now we're overtaxing a system, right, that is already incredibly fragile. And not to say that these are not good things to know, right? But in terms of a capacity perspective, from a staffing clinical perspective, and with the shortages of physicians that seems like it's going to continue to grow, are we at risk of kind of surfacing a bunch of needs and kind of services that are required that we simply are not positioned to deliver, whether we know it or not? And there's a threshold somewhere there, right? And again, it's almost more of a moral dilemma that I think we may find ourselves in. But is there a scenario here in which, with all of the tools and technologies, that we simply uncover a lot of needs that we are not able to address right now as it is? And so that ceiling is what concerns me to some degree. Now, we may not get there. Maybe the technology won't ever get there, but I have to assume that the possibility of that is there. So thoughts on that? And
Sure, I can comment, but probably not offer a solution. I mean, this clearly was the issue in Yuma, as probably in the last administration's mandate was to work on social determinants of health. So as we adopted the tools from Epic on that, I mean, we clearly were trying to do workflows where we have to refer to community health workers or other, SDOH resources. And when we partner with Contexture, the state, Arizona State Health Information Exchange, there was really, we tried to redirect the referrals within Yuma County and we had nothing. We were told to go back up to Phoenix. And can you imagine a patient trying to get SDOH resources 2 hours away? That's impossible, right? So I think it doesn't require generative AI to run through a registry to tell you these problems. These are probably societal problems that, we as a society need to make a decision. What do we want to support? What are we going to tell our, congressional representatives what to do? And so I think it's a great discussion to, publicly surface. I don't think it takes AI to tell us those things.
Well, that's terrific. I want to, so my final question was going to be, what does success look like about 10 years from now? But I think you're about at 4 o'clock just about. And so maybe that's a question for the next panel, which is the Paths Forward panel that's going to start shortly. But I want to thank all of my panelists here, particularly Dr. Chang for coming from Yuma. Really appreciate all of the insights. If I get a round of applause for our panel, I really appreciate it. Thank you very much. Great, thank you.
Hey, thanks. Yeah, good to see you. Good to see you, McCall.
Good to go. I appreciate it.
Thank you.
Yeah.
You want to come up here? Done? So we're gonna.
Baby, you got it? Baby, you got it? I'm about to. Hold on, where's the clacker at?
Wait, turn this on.
On the top.
Right here, right here. I'm sorry. Right there. Now it's green.
Okay, we're going to go ahead and get into our next panel, if I can get the panelists up here. Although Jason set the stage perfectly for that, so maybe he should be the moderator and I'll go sit back down. But it's hard to sort of follow all the great panels today and the discussions. And you know what I was hoping with this panel, what we could do is we could just talk about, you know, where do we see are the opportunities from all the great discussions today? Unfortunately, we couldn't get everyone up in one big discussion because, you know, you can't separate rural health and telemedicine and public health from primary care and from all of these different things. They're all interrelated for health impacts. And so, you know, when I was listening to the last panel, since there were too many good questions for me to speak, I'll ask this one now of these people. You know, something that I started working with people creating the first, who created, I had nothing to do with it, the first private public health information exchange across the state. And, you know, that was supposed to integrate disease surveillance, private practice, improve the quality of care for everyone. That was in the late 2000s. And, you know, have we seen any change there? And what, you know, is this something, you know, people, well, we talk about in computer science that, you know, there's this opportunity. And one thing that I focus on is how can we use this innovation in technology and the commoditization of advanced analytics and accessibility to people to really help get rid of health disparities and access and improve overall systems versus increasing the digital divide, et cetera. So, you know, from today in the discussions, what great ideas have come up for the panel? And, you know, where do you think are the easy, low-hanging fruit where we as, you know, the people in this room from this community can make an impact? Low-hanging question for you.
Well, you know, I think that, you know, what I came away with this afternoon's discussion really is, you know, where are the needs for AI implementation? And of course, I think they're kind of across the board, but where can we make an impact with the implementation of artificial intelligence in various ways, particularly in healthcare? And I really like the discussion on access because access also involves rural health. It involves patients across the spectrum at getting the services that they need. And so leveraging AI for that perspective to get patients the care that they need where they are, I think will be something that will be measurable in the future, whether it's 5 years from now or 10 years from now. So I think access certainly is one of them. And again, that's something I would ask my health system colleagues if that's something that they're thinking about as well too when they're implementing AI strategies, you know, across the board for the AMCs.
So I think one of the there we go. Okay. Is, you know, we talk about how, is AI smart enough? And I wonder if we're asking the wrong question. And maybe the question is AI too ignorant? Because if you think about the question of ear infection, right, and AI doing that better than a human. Well, for an isolated presentation of ear infection, that's probably true. But children are seen over time. And so if you know a child has a particular pattern that completely changes your Bayesian prior probabilities and it changes your prediction. So if we look at the areas where AI seems to be doing well, it's where the information that is needed to make the decision is fairly constrained, because AI takes a massive amount of data to train, but often when it's looking at a case, it's looking at a fairly limited example, in part because it doesn't routinely scan the entire medical record, in part because it can't, because our healthcare system is fragmented. So thinking about those cases where what's in front of me today is what I need to make the answer, may be the areas where we're going to have the greatest impact. And I think back to early days of decision support, right? And I don't remember who it was said, what you learn as a doctor is how to override an alert. If you look at antibiotics, right? The whole issue of penicillin allergy versus cephalosporins, right? Most of the time when that would pop up, yes, we knew the patient said they had a penicillin allergy. Even when they had paper charts, it was written on the top of the paper chart. It's flagged in red, in yellow on the EHR. But you also know that the probability the patient with a penicillin allergy is going to cross-react with cephalosporin is low, and you've already run that risk-benefit calculation when you say, okay, I'm going to give them a cephalosporin. But the decision support didn't have that context. It would just throw this up so that, in fact, you get these 97% override rates. Because it was ignorant. It was looking at a very narrow thing, right? Which is just allergy, drug A, prescription drug B. It didn't actually look at the record and say, gee, we've given this person cephalosporins 5 times and they never had a problem. So I think imaging in many cases is a great case where what's on the film is 90% of it. Occasionally, I need to see the old film. But it's typically not, I need to see every film this patient ever had in order to judge this. It's like, give me this film and the previous film, and 99% of the time, I can do the job. And so as we're looking at our targets, pick the ones where the information you need is right there in front of you, and AI will have a very good chance.
Right. Slightly different takeaway from the meeting today. To me, it seems like AI in healthcare is not so much of a technology problem, but more of an implementation problem right now. It's the institutional readiness. It seems to be the problem right now, in the sense that there's a lot of rush. Industry is bombarding us with the models, and there is also appetite to purchase the models right now, but not a lot of institutions are thinking about the infrastructure before and after implementing the model, how to monitor the drifts and things like that. Other speakers have talked about, and also change management. I think our keynote speaker highlighted the need for that emphasis on change management. Without that, I think AI models are probably not going to make a difference. And lastly, governance and accountability. These seems to be a key key issues which are underappreciated. That's my takeaway for today.
So these are great points. Dan?
Just wondered a question on, we used to talk a lot about the triple aim, enhancing the patient experience of care, both quality and satisfaction, decreasing the per capita costs, maybe even the quadruple aim to bring back the joy. I worry sometimes that we focus too much on, protecting our silos, our hoarded resources, and not getting them to where we need to really address unmet needs in our rural, tribal, border communities in a state like ours. So how does AI really help us get closer to the triple or quadruple aim kind of things, which I think are laudable principles? Is it something that can really get us closer? I don't worry as much about whether procedural specialists or surgeons making the top 1% of income earners in the country or family physicians. Still, we say we're underpaid, but we're still in the top 5% of income earners. We're paying twice per capita of any other developed country, and yet our health outcomes aren't as good. Will AI get us closer to achieving some of those things?
I think, my first take on that as just a comment is what it really brings to mind is, what you're talking about is this really is not, it's not a pure technology problem. It's not, a medicine problem and getting the accuracy in it. It's an engineering problem. It's a social problem. It's an education problem. It's a business problem, right? We need business experts. We need, industrial engineering experts, we need human factors people, we need sociologists, we need all of that in there, and we need the education of the people who are practicing as well as our public, right? And someone made a statement that 1/6 of the population is getting their first recommendations from chat programs. Statistics I saw recently was over 35% of the population in their 30s, their primary source of health and what they do they take action on what they get from the chat engines and from Google, which is in essence LLM in the back. It's got AI in the background anyway. So, that's what's happening. And so, instead of being concerned as, someone, it's like, how do we use what they're getting there? And can that be turned into something that's making them more knowledgeable and making them more cognizant about what's going on with themselves so that they're able to contribute actively into the discussion, right? Unfortunately, I'm a scientist and engineer. I question everything, right? My whole job as an academic is to question my students, to question any software I see, to question everything. And so I have no problem questioning any system or anything like that. I tend to have some family members that when they go in and see a medical professional, they just take what's said and they won't ask the questions that they have because they feel, that they aren't qualified to go against the judgment that's there. It's just like, I make the comment that people with certain accents, to me, can sound very authoritative when they have no more knowledge than I do. And it almost got me killed a couple times hiking from listening to a friend. But, he just sounded so authoritative. And, it is this dialogue and it is the active participation of everyone. And, but I think, AI can help. The AI enhanced tools can help with some of that. But we need to figure out how we can go and get that so people are more active and feel empowered, right? And to be a partner in what's going on with them and not just the recipient, right? So to me, that gets to some of it. And if they feel that way, then maybe they're being more proactive about their health. And that leads to better health outcomes. But that's just one idea. Response.
No, I'm going to get myself in trouble here. That we spend a lot of time talking about health equity and the digital divide. And I think that what we need to do is rather say, for these populations which are not getting adequate care, adequate coverage, how can we use the digital tools to improve that? So thinking more of a rising tide raising all boats. We talked a lot about, the digital divide and the connectivity divide. But as connectivity rose broadly, right, Thanaotham Community College is now one of the largest providers of online education in the state, if not the country. And we have broadband to all of the reservations. So focusing on what tools we can bring into those environments that will make a quantum change. If we think about the presence of diabetes broadly, right? Having AI tools that can provide guidance remotely rather than requiring them to connect. And we won't necessarily in the short term save money. The IdeaTel, the largest diabetes telemedicine project that was fielded, it was the largest telemedicine network by a factor of 4 when it launched. And the question was, would it improve care and reduce cost? Well, what we found out was it definitely improved care. But we also learned that medically underserved regions actually are medically underserved. And these people were not getting their eye exams, and they were not getting their foot exams, and they were not getting their dosages adjusted. And so when they were connected with telemedicine and the nurse convinced them to get in the car and drive 2 hours to get their eye exam, they were getting their eye exams, and the cost of those eye exams and foot exams actually raised their cost of care in the short term. Now, it meant they weren't going blind and they weren't losing their feet in 10 years, but in the short term, it raised cost. So focusing on how we can make improvements in these populations, I think, is where, what tools can we use to make incremental gains? I think there's a hand.
We have a question in the back.
Thank you. So we talked a lot about the opportunities of AI. And we looked at the patients, we looked at the hospitals as the providers. The third group involved in healthcare is insurances. And they can be a big facilitator. I also could see that they are a big threat to the implementation of AI, because we live in a society where insurances can deny insurance to patients. So are we thinking about working on policies that the AI tools are not abused to deselect patients? And would it be something for the university and academia to really get involved early on in shaping these policies, how to use the AI tools?
Peter, that's a really loaded question. So I do think that's a very important question. And I think this is where policy governance and all those things come up. I do believe there's appetite among politicians right now to get involved for all the reasons you mentioned. Somebody could be selectively not get insurance because their information is out there through the AI models or whatnot. I don't have a good answer, but I do think, so Dr. Slepian probably has an answer, so he's raising his hand. But I think that's an important issue, so.
What I was going to say is that in the state of Arizona, we have HB 2175, which is basically a bill which is directly aimed at that issue, which is if somebody's denied based on some AI-based kind of claim, it has to have human oversight to adjudicate the problem. And, so the whole regulation of AI is a complicated thing. We don't really have we used to have a plan for regulation. I've been involved in this. I was on the federal commission with USPTO, with the Department of Commerce. We used to have a plan to have a sort of national program that got thrown out under the current administration. We have the current plan, but the most recent, and then 50 states, I'd say about 38 to 40, have some degree of regulation related to AI. The most recent thing that came down is an executive order from the president in December, which basically said that we cannot have this patchwork of individual states, that therefore we're going to have a sort of national strategy, which is sort of hands-off on a lot of this regulation. That instantly creates a constitutional crisis, not that we don't have enough. So that's a supremacy clause problem that has to be addressed, but that's a separate matter. So back to sort of, since I have the mic for a second, I think, to go forward, you have to really address, and a lot of good points are here. I think you have to decide, what do you really want to tackle? Do we want to tackle, what's the unmet need that we really want to address? And then, think about how AI can fit into it. I think there are a lot of ways I've been very involved, giving talks all over the world on AI. So I think one thing is you either want to look at the access issue, that's talked about a lot. The other issue is, do we lay AI into the natural history of the patient, from birth to youth, adolescence, beyond, and where are we going to be applying? What's our target? Then the other strategy is, do we think about AI in terms of enterprise management? Do we think about AI in terms of facilitated diagnostics, therapeutics? Then there's the angle of, are we thinking about AI from a descriptive point of view, from a predictive point of view, or from a prescriptive point of view? The prescriptive AI side is scary, because that's where it becomes autonomous and we give up a lot of control. So I don't think we want to go there. But what you were talking about before in the access thing is, and as you said, the cost would go up transiently and then it would go down. That's a social thing. And then you have to think multi-scale in terms of you're dealing with the patient, but now you have to think about the family, the community, society, that we want to educate people to a new way of delivering care. So for patients to have more responsibility, get out in front of themselves. And then since, 60 to 70% of the world has cell phones, we can think about things from that kind of perspective. So if we drill all of what I just said back down to Arizona, if you want to think about access, think about, what are the issues, where are the communities, what are the tools? It's like what you said. And then pick the top diseases that you really want to address, and then perhaps go into that educational program based on what you could do there. Now, interestingly, we have a project right now with students where we've looked at the knowledge base of a wide range of LLMs as far as different specialties of medicine. Cardiology knows a lot. Renal medicine knows very little. And actually that correlates dramatically to the number of publications that are out there and to the number of board-certified subspecialists that exist in each area. And we have a paper that's going in right now on this topic. So, I think we have to be careful about what's on the web and in LLMs, because you still can't get the source as well. That's a problem. We had library, you looked up a book. Then we have the web. You at least can get sort of the resource, the reference. But then we have AI where it's all kind of mushed up, and we don't really know what's going on. Perplexity may be a little bit better. It gives you more references, but if you try to get the real reference from chat or from Claude or Llama or Lambda or any other things, DeepSeek is really not accurate at all. We've looked at that in a very big way. So I think there's a lot of issues here. David, you're the science engineer. We got to question all these things before we just unleash everything. But I think if we define the question first and what the target is, then we could address a lot of these things in a more substantive way. So I'll stop.
I agree in terms of looking at the different areas. Being a comprehensive university, we already have a lot of work, just like your work at a lot of the panelists here today, working on separate parts of that. And what we're really trying to do is, where do we accelerate? Where can we grow even bigger presence and have an impact that will be even larger? And so that's what we're trying to focus on. And, you know, the policy, the use, and the transparency of what's there and accuracy models are something I've collaborated with people and done things for numerous years on explainable AI and transparency of data analysis, because it's so critical. I was telling someone earlier, I always said that I would never let a surgeon operate on me from a volumetric 3D reconstruction unless I got to see the software parameters that they were using for it, because I know enough about it to know how you can easily set things wrong and completely diagnose carotid stenosis, right? You know, and so this is the type of stuff. I'm a software engineer. I think it is the field that has the worst track record of producing reliable, dependable systems. And every time you get an update for one of your computers, that's shown. I mean, the rest of engineering, and it's also the things you know about, you understand all the problems. The things you don't, I don't worry about, you know, airplane safety because, you know, of people I talk to at Boeing, but I have no idea everything that goes on that's never reported. First time I went up in a rescue helicopter and they went through a checklist before we took off, and there were 8 things that they said failed and said, good to go. And we took off. I was freaking out, you know, because I assumed if something on the checklist failed, it meant you didn't go, right? But it's, the safety issue is critical. You know, NIST had started a very good program that I participated in, and people around the country participated in, the AI Safety Consortium, to try to set communal standards on safety to work with, and they had companies that bought in. There were a couple companies that were creating their own that we participated in. And then, you know, 2025 happened and that all got put on hold. But that doesn't mean we can't do it and can't demand it from the providers that we have. But this is a very big thing. And, you know, what we're trying to do is take all of the organic growth in what people have been doing with machine learning and AI, the excellence across the university, grow it, converge it, and move it to have the biggest impact. And I think a clear, you know, area for that is to make sure that we're educating people right, you know, and we're producing our graduates. I had, you know, world-renowned colleague when we had a site visit for a national center, and they talked about, you know, the impact. And he said, you know, all my research publications cite the impact. He said, the biggest impact I've had on this world are the students I've graduated and trained, right? And I think all of us in academia feel the same way. You know, hopefully our students do much better than we did and continue growing that. But we all have this mission and the people we interact with, right? And if we create that right culture, and the thing that I was so happy to see today, and I felt a sense of reassurance, is everyone in the room talked about using AI responsibly. This was not, and you know, about how they were using it effectively, the concern they had, but they wanted to make sure that people were thinking about the societal impact, the ethical impact, the legal impact of everything they're doing with this. And that we have such a groundswell of people in that realm, because there are, you know, lots of people who don't think about those things. And so we already have that sort of ingrained culture. I've said since coming here, I was at another land-grant university for 20 years, that, you know, we had a huge ag program, a huge manufacturing extension, et cetera. But the land-grant mission of the community didn't seem in the DNA like it does here at the University of Arizona, right? Everyone believes, and we're really here to improve everything in the world that we live in, right? And so that's the charge that I see us having in this. And Karthik, did you have a question? Yes. I thought so. He can solve all the implementation and getting it out for while you use across all.
Thank you, David. So this question goes to all the panelists. When I think about AI, or for that matter, any digital transformation that we've gone through, right? You can put them in 3 buckets. One is we were doing some stuff, we are using this new tool to do the same stuff. right? Operational efficiency. Srikar, I came in towards the end of the last panel session where you made that comment, right? The second is where we have a hammer and we are trying to look for similar looking nails here, right? And so I think there are enough ideas that we could do taking AI for various diagnoses and things like that that we could do, right? These are both innovative. These are both really value-adding stuff. But as research institution, we need to be thinking about rearranging the table and using AI to power something. Let me give you a figurative example to explain this. When in the past, when we had steam turbines running the shop floors, what used to happen was the steam turbine would be outside and the power to the shop floors would come through rods that were running up on the top, and you had a conveyor belt connected to that machine to run it. When those steam engines were replaced by electric motors, the first thing people did was they replaced the electric motors outside, but had the same shop floor as before, right? And then there was an innovation that somebody said, we don't need one motor, big motor outside. What if we attach these motors to those individual machines and move them around to generate value, right? And in my digital transformation class, that's what I talk about. So going with the Paths Forward panel, the title of the panel, what do you see are those ideas where we can truly reorganize the way we do stuff? Even if you're not completely certain, would love to hear your views on this.
Well, a corollary to that is that humans overestimate the pace of change in the short term, and they underestimate the magnitude of change in the long term, in part because we are very bad at envisioning the fundamentally different way of doing something, right? You know, the first cars were steered with reins because that's how you steered horses. And it took a while for us to think of, well, let's do it completely differently because now we can do it completely differently. So I almost think that I'm not smart enough to envision that. But what's very clear from these talks is that the pace of change of the technology is a quantum order faster than even the technology change people are used to dealing with. And so the most critical thing for us over the next few years is nimbleness. That we can't set a course today and assume it's going to be valid 6 months or a year from now. And so as an organization, we need to actually think about how we become more nimble, how we field classes in weeks rather than months or years, how we bring degrees up in months rather than years. Because everything is going to be changing so fast that if we do our internal processes at the university the way we have, we will always be solving yesterday's problems.
I think additionally, I think to your point, one of the things that we came about here is the importance of partnerships. And so that's why we have a lot of folks here today from different sectors of not just in the economy and the health system, in the academia as well too. And so it's going to be important, I think, to partner with some of these big tech firms that are developing these new models, particularly the physicians and the healthcare experts to help lend that credibility and those guardrails as well too. And so you had the example of the airplane having a checklist. And so over the last 20 years or so in surgery, there's been a movement to actually have checklists as well too. And so before the patient goes to sleep, there's a checklist. Do we have everything that we need for the operation? And so maybe at the same time that there needs to be developed some checklists for the AI algorithm or for implementation of the results of that algorithm before it's then applied to the patient. References as well, I think, is a good point, and transparency and being able to then go back to the initial source might be part of that checklist. And so those are a couple of things, to your point, I think that we're taking away today, and particularly, I think, the development of these partnerships. And so throughout the rest of the day and the cocktail reception this afternoon, think about developing those partnerships and collaborations among the group here.
Just going back to Karthik, what you said about reorganizing, I think there's definitely appetite for that, and there's obviously some movement towards it. And not to be repetitive, Dr. Josh Lee kind of presented some of the things they've been doing, which is sort of like reorganizing what they have been doing for years and now becoming much more efficient by doing. So I think I see what your point is, but I think there is definitely appetite, and also there is some evidence that we're reorganizing ourselves. I don't know if this is a great example. Dr. Wertheim can tell. Robotic surgeries, we're reorganizing, right? How we operate people, right? Sort of like we're not doing the same thing we've been doing for all these years, right? The outcomes are different and the way we're doing are different. So the checklist is different. So there are many examples like that. I think we are reorganizing what we're doing, I think, healthcare space.
And one of the things that I would say from what you were saying there sort of comes back to the role that I see the university can be in all of this, is being the impartial convener and having expert knowledge to add to the solution of this large scale problem. You probably remember the Reagan Street for Healthcare Engineering, right? Reagan Street Foundation founded 2 institutes. And they were really on the efficiency of medical operation, because this efficiency expert who became incredibly rich started having people get sick, and he went through the healthcare system and said, this is completely inefficient, right? And so the Archie Center was really set up, and they were trying to bring together the insurance companies, the drug companies, the medical providers, working together and being that impartial body to take concerns, find new models, and innovate, and then have the university be that trusted source of information that people would never share with each other, right? There isn't free sharing of everything between those 3 parties in our current system, the way it's set up. It's sort of an adversarial system. And so these ideas of redesigning how we attack a problem and what is the way and how this technology can fit in, that's a great use of a university, right? Because we don't have the vested interest in terms of the profitability of what's coming out in this. And so, this is a case where, and we can convene experts and experts around the world, right? That's what we do as, faculty. We bring people together and find the right team to make decisions. And so this is the type of approach that, as we do it in a convergent manner across disciplines and bring all of these different aspects together, we can start thinking of, nutrition education and K through 12 education, and what we can do through K through 12 that ends up, allowing us to have healthier aging, right? 20, 30, 40 years down the road, and really start these type of things. So I think that's a really good role. And I think the ability of this technology that's coming in to be able, through LLMs, through machine learning algorithms, to be able to synthesize things and to help break down the discipline barriers, it can be a good translator and allow people to feel like they can negotiate in a common space. I mean, I do think that's something that we are really trying to do here. And so our partnership, our networks are key to everything that we do. And I think there's a great opportunity for that. But what a great question. To sort of end this. Thank you to the panelists who did wonderful jobs sharing and offered their great insights. So thank you very much. And, just to end the day, there were a lot of people who worked a long time to bring today together. And first and foremost, I want to thank all of you for attending today, being active, engaging us. But I really want to thank the enormous amount of people who helped make this event so successful and put in so much time. They made those of us who wanted to bring people together and had ideas, they made it happen. They were able to say, yes, we can do that, and then come back with a plan to be able to do it. So we really appreciate all the hard work of the ORP team, and we thank you all for your time. We hope that this has started an interaction with all of you and it continues to grow. We're going to be doing AI health speaker series that we're going to be launching and bringing people from across the country. We're going to be doing a fall symposium to try to get, now the one thing we don't have here are the providers of these tools, the large companies, right? We don't have the OpenAI, we don't have Microsoft, we don't have Google here. And, you know, how do we bring those people in as well into this? We don't have Epic, we don't have Cerner. You know, how do we bring all of that into this conversation with the amazing expertise we have here? So that's what we'll be planning for the fall. But I think what you've really seen is the challenges we're facing. There's really hard challenges. And we aren't going to make, you know, we aren't going to solve this in the next 2 years. You know, but if you happen to be here for Tomas's introduction in the morning, he talked about how do you go from, 0 point ignition where you're getting positive energy from fusion, and then you spend the next 6 to 12 hours re-instrumenting and fixing material so that you can do that again to a 24/7 power plant that's sitting in each town across the country. That's a huge challenge, right? So these are the type of things that the university is set up to do and what we're charged with. And, you know, I really appreciate all the passion and the insights. And, you know, to me, all of the panels were great. It's great when we have different opinions and people are very passionate about it so that it makes us think and re-examine things more. And I really think it's our time for us to take an active role and really lead in this healthcare transformation. So, you know, I think you've seen a lot of great work from all of our partners and all of the experts assembled today. I've heard lots of great stories of what all of you are doing. We have so many people, we couldn't stick them all on panels, or each person would have had 10 seconds to be able to talk about their amazing work. But, you know, we're really committed to this mission of improving health outcomes. And, you know, the passion and the insights from everyone today and the enthusiasm, you know, is great reinforcement that we're really working on something important and we have the support of a large community. And, you know, my job and the job of our team is to help all of you succeed better and guide and bring the resources and help us get to that point where we're really thinking about the fact that, you know, most care becomes preventative, and in rare cases, you need healthcare professionals, because that's one way to deal with the shortage of doctors, is if we didn't have the need for them as much. And, you know, earlier diagnosis, earlier treatment, more success from initial visits and outcomes. And these are the type of things we have people actively working on. So it's been so exciting to me. For those of you who don't know, I just joined here in May. But talking to people, and we're actually talking about, you know, doing a cancer biopsy of a patient, finding the specific genomic information of that cancer, taking their information and predicting all the possible mutations, creating immunotherapy, giving them a shot to turn their T cells active to fight the cancer even at stage 4 and cure them. Those are the type of things that are just so amazing that people are thinking about and figuring out how we can help them do that. But also, how can we help people with their everyday problems and really increase the effectiveness of everything we do? So I'm always very humbled by the expertise and the dedication of everyone here. So thank you very much for this. I hope you stay around and talk. We have some poster sessions. We've got some live training sessions from our Aztec group, and you'll be able to see all of that. So please continue the discussion outside. Thank you very much.